Welcome to day one of this two-day webinar series, which is organized by the EMA's Early Career Working Group and in collaboration with the European Society of Endocrinology, the European Network of Trainees in Obstetrics and Gynecology, and the World Association of Trainees in Obstetrics and Gynecology. My name is Irene Lambrinidaki, and I'm Professor of Endocrinology in the University of Athens in Greece and Scientific Director of EMAS. Menopause care is complex and needs a multidisciplinary approach. Endocrinologists and gynecologists are the main specialties who take care of women transitioning into menopause. However, in many cases, referral to other specialties are needed, such as psychiatrists or cardiologists. Therefore, joint educational activities are of paramount importance. And I'm very glad that such interdisciplinary webinars take place because the exchange of opinions and experiences between specialties are so very educational. Now I would like to give the floor to my co-chair, Dr. Christina Saravinovska.
Many thanks, Professor Lambrinidaki. First, I have to say that it is truly a special honor to be co-chairing this joint webinar with you today. And with this, I would like to say thank you for your inspiring words on the importance of multidisciplinary approach in women's health, especially when it comes to perimenopause and postmenopause. I think that we often overlook how important it is to include different specialties in order to tackle different challenges when it comes to women's health per se. My name is Kristina Saravinovska. I'm an internal medicine resident and junior research assistant at the University Clinical Center of Serbia. And I'm here today representing the European Society of Endocrinology, where I serve as the co-chair of the Early Career Committee, that is EYES, where I also lead the EYES Observership Program. However, at the same time, I'm a member of the Early Career Working Group of the European Menopause and Andropause Society, that is EMAS, and I have to say that it has been truly a joy to be part of this initiative and to collaborate across these four societies in order to create a platform which is inclusive and supports early career professionals. And I want to say that today we truly have an excellent program ahead of us. We will hear 4 expert talks from leading specialists in the field from their respective societies, and we will also have 2 multidisciplinary case discussions where all speakers, moderators, and chairs will come together to share their perspectives. After each presentation, that is lecture, we will have a short Q&A session, and I encourage every single one of you to actively participate by submitting your questions through the Q&A box. I also encourage you to share your thoughts in the chat box as well. During the case discussions, we will also have interactive polls, so I also invite you to stay engaged in this matter as well. I would like to highlight a very important thing, and this is that this joint webinar is accredited with 4 European CME credits, which will be awarded based on your attendance during the live session. And without further ado, it is my great pleasure to introduce our first speaker for today with her talk, The Menopausal Transition, Symptomatology, Hormonal Alterations, and Cardiovascular Risk. This talk will be delivered by Dr. Liliana Marina, who is an MD, PhD, Senior Research Associate, which is equivalent to Associate Professor of Endocrinology. Dr. Marina works at the National Center for Infertility and Endocrinology of Gender at the University Clinical Center of Serbia. She actively contributes to the field of adrenal gland and reproductive endocrinology. Dr. Marina is also a member of the European Society of Endocrinology Clinical Committee. And without further ado, I would like to ask Dr. Marina to take the virtual stage, share her presentation, and I'm sure deliver an outstanding talk.
Thank you, Christina. Thank you, Professor Lambrinidaki, and to the entire board who organized this wonderful meeting. You truly are a driving force of changes in how we collaborate and work together in this multidisciplinary field. I will now share my presentation to make sure that technically wise, everything is okay. You do see it, right? Okay. So this is a full screen now. Perfect. Okay, I just need to move my screen. Okay. And do you see my presentation? Okay. So again, super happy to be here. Many thanks to the European Society of Endocrinology and the Early Committee EYES for inviting me to be here. The title of the talk is challenging. It's the menopausal transition and the three topics for which I have a 15 minutes time. So I hope I will be able to give a short overview of each, and each of these can take more than an hour to talk about. So I will be talking about symptomatology, hormonal alterations, and cardiovascular risk. I come from the Clinic of Endocrinology, Diabetes and Metabolic Diseases at the University Clinical Center of Serbia, where we see these patients daily as endocrinologists, often presenting with confusing symptom patterns that require a nuanced understanding of the underlying physiology. So, perimenopause, menopausal transition, menopause, and postmenopause are not synonyms, and each refer to distinct phases with different clinical implications, yet they are used as synonyms in everyday life and also scientific literature. The reproductive aging continuum is divided into distinct stages according to Stroh plus 10-stage system, which remains the imperfect but still our gold standard. The menopausal transition encompasses stages -2 through -1, preceding the final menstrual period or so-called menopause. Menopausal transition typically spans 4 to 8 years with substantial individual variation. Understanding this timeline is essential for counseling our patients who may wonder why their symptoms persist or fluctuate over years. The definition of menopause is very troublesome, and it is most likely the reason why there is so much confusion. You see, menopause is the same as the final menstrual period, diagnosed retrospectively after 12 months of amenorrhea. This 12 months period, according to Stroh, is a part of postmenopause. But if we are using other terminology, then this period is a part of perimenopause, the ending part of perimenopause. So perimenopause lasts 12 months longer than menopausal transition, and they start at the same time. My patients think that final menstrual period cannot be the same as menopause, and they think that this is in fact conflicting. And if you ask me, I have to say that I agree with them. And to be able to understand this period to my patients more easily, we say that menopause is actually this 12 months of a pausing in menstruation. So not only the one point in time. And then my patients do understand better that postmenopause starts after this 12 months period. However, we will not be using today only menopausal transition because then it would be impossible for me to present data because perimenopause and menopausal transition, even in the literature, are used interchangeably, and the current knowledge in literature data uses both of these terms. Early menopausal transition is marked by increased variability in menstrual cycle length, defined as a persistent difference of 7 days or more in the length of consecutive cycles. Persistent is defined as recurrence within 10 cycles of the first variable length cycle. Now you see here the latest European Society of Endocrinology clinical practice guideline. In the title, it carries menopause and perimenopause. So because these two different terms start at the same time, then we will lean on this definition that the panel recommends that perimenopause is considered when menstrual irregularity and or vasomotor symptoms are present even in younger women in between 40 and 45 years. And you can see here that they recommend biochemical testing for diagnosis or management of perimenopause in women older only younger than 45, older than 45 is not necessary. And when it comes to hormonal changes during the menopausal transition, the explanation demands that we separate this period from the late reproductive stage and from the amenorrhoic period of 12 months. So this diagram, which I developed for teaching purposes, illustrates the orchestrated hormonal changes across the transition. Starting from the left, you can see that inhibin B and AMH, our ovarian reserve markers, begin declining years before any menstrual changes occur. This is the earliest endocrine signal of reproductive aging. As follicle numbers decline, the hypothalamic pituitary ovarian axis compensates. FSH rises, initially in a monotropic pattern, attempting to drive follicle recruitment. This is the body's compensatory mechanism. You see that estradiol, the yellow lines, initially remain stable due to this FSH-driven compensation, but eventually becomes erratic with extreme fluctuations from time to time that can reach supraphysiological peaks before the eventual decline. LH rises later than FSH, contributing to the altered gonadotropin ratio, which we see in perimenopause. Hormonal chaos precedes hormonal deficiency, and this explains why symptoms can be so unpredictable during the transition, and this also explains how different these two phases are. So in this slide over here, you can see progesterone as well. As ovulatory cycles become irregular and anovulation increases, progesterone exposure decreases substantially before estradiol falls. This is clinically very important. The early loss of progesterone, while estrogen remains variable or even elevated, creates a state of relative estrogen dominance. This may contribute to heavy menstrual bleeding, breast tenderness, and mood disturbances that many women experience in the early menopausal transition. The progesterone deficit also has metabolic implications. It has anxiolytic properties and affects sleep architecture. Its loss contributes to the sleep disturbances and anxiety that often precede the classic vasomotor symptoms. Understanding this progesterone first decline helps explain why some early perimenopausal women feel hormonal despite having normal estradiol levels. Their estrogen to progesterone ratio has shifted, and this also has therapeutic implications. Some women in early perimenopause do benefit from cyclic progestogen therapy to restore hormonal balance, even when estrogen therapy is not yet indicated. Despite the fact that sleep disturbance, depression, and brain fog can precede vasomotor symptoms, the only defining symptoms of menopausal transition, according to Stroh, are vasomotor symptoms alone. And not only according to Stroh, but also according to majority of other society. This is a very interesting study published by Aras, which was published in Scientific Reports in 2025, using a clustering approach to analyze over 145,000 symptom logs. The methodological innovation here is important. Rather than studying symptoms in isolation, this research used cluster analysis to identify natural symptom groupings across reproductive stages. On the left, you see the clustering methodology applied to identify distinct symptom phenotypes. You see here how they have divided patients according to menstruation in the last 12 months period. If they were not menstruating in the last 12 months, they were considered menopausal. If they were menstruating, then they were premenopausal or perimenopausal if they also had vasomotor symptoms. The methodological challenge here is how many perimenopausal patients ended up in the premenopausal group simply because they did not have vasomotor symptoms. This is, in general, a fundamental challenge in menopause research. We often use vasomotor symptoms as a marker for menopausal status, but we know that symptoms are highly variable. Some women in genuine hormonal perimenopause may be misclassified as premenopausal because they lack hot flashes. This potential misclassification for sure is affecting all comparative studies between pre and perimenopausal women, and it is a limitation that we must acknowledge when interpreting the literature. So what did Aras et al. Showed? They showed that symptom burden of the menopausal transition extends far beyond hot flashes. While vasomotor symptoms remain the hallmark, this research confirms the high prevalence of sleep disturbances, cognitive symptoms, often called brain fog, mood changes, including anxiety and irritability, musculoskeletal complaints, and fatigue. Further, the interconnected web on the left demonstrated how symptoms do not exist in isolation. Each node represents a symptom, and the connections show statistical associations, symptoms that tend to co-occur. This network perspective has therapeutic implications. If we can identify a woman's dominant symptom cluster, then we may be able to target interventions more effectively. A woman whose primary complaint is insomnia with secondary hot flashes may need a different treatment approach than one with predominant mood symptoms. The clustering approach also helps explain why the same hormone treatment can have vastly different effectiveness across patients because the underlying symptom phenotypes differ. And maybe most important finding was that while hot flashes are the classic marker, they showed less stage-specific variations than expected, and they accounted for no connection to mood, cognitive, digestive, or sexual symptoms in isolation, challenging the assumption that treating hot flashes alone will resolve the full symptom picture. Coming to cardiovascular risks. One of the most persistent misconceptions of reproductive aging is that cardiovascular risk is a postmenopausal problem. However, data from multiple prospective cohort studies show that the metabolic and vascular changes begin during the transition itself. Before menopausal transition of LDL begins to rise, LDL begins to rise like a silent warning, which simply says something is changing. At that time, blood pressure has not yet changed. And then with menopausal transition onset, LDL rises significantly by approximately 10 to 15% over the transition period, according to pooled SWAN data. HDL begins to fall. C-reactive protein rises, indicating systemic low-grade inflammation. Insulin resistance increases. These are classical markers of metabolic syndrome onset, and they are occurring in women who still have regular or near regular cycles. Furthermore, aortic stiffness increases measurably. Carotid intima media thickness progression accelerates. Blood pressure begins to rise. Subclinical atherosclerosis is underway. During the early postmenopause, the process accelerates. Coronary artery calcification increases rapidly, and this is where most clinical trials start enrolling their so-called recently menopausal women, but the vascular changes are already there. The timing hypothesis states that the cardiovascular benefit of menopause hormone treatment is only achieved when treatment is initiated close to final menstrual period in women whose vessels are still estrogen responsive. However, even then may already be too late if the vascular changes began during menopausal transition. So to summarize, one size fits none. If you are confused with STRO and the other reproductive aging definitions, don't worry. As you have seen, you are not the only one. Everyone is confused. We need a new, more comprehensive and systematic understanding of reproductive aging in women. We need this in order to obtain high-quality data based on homogeneous, predefined definitions of reproductive stages. We need to listen to our patients more and start understanding late reproductive stages as well in order to better understand the menopausal transition. Cardiovascular changes start early, and we don't have data to show if and how the early treatment could or would be beneficial. We can't be treating menopausal transition and postmenopause the same. You've seen the hormonal changes and you've seen the symptoms. We need more reliable, high-quality studies, and we rely on you. Thank you.
Many thanks, Dr. Marina, for this, I would say, phenomenal talk. I think it really set the stage for today's webinar. I would now start with the questions. Combine several. There are some similar questions. The first, let's say 2 or 3. Do you start cyclic progesterone alone in perimenopausal women? And how do you decide whether to add estrogen? Is it worth it given the increased risk of breast cancer?
Let's start one at a time. Thank you so much. Yes, I do. We do. Our women are very much informed about menopausal transition and even of the life before that. They are demanding answers. So they're not happy with all of the definitions that are out there. They're reading papers, they're reading leaflets for patients, they're following podcasts, and they're like, we don't understand anything. Nobody understands us. And we have to agree that we should be understanding them, and trying to help them. Progesterone is a wonderful medication, and for many of our patients, does wonder. Yes, we do start early with progesterone in those patients who come and say, either I'm not sleeping anymore, my menstrual cycles are regular, or, for example, the cycles are regular, but they are a little bit shorter than they're before. And she's a little bit more nervous than before, and her PMS is more accentuated. So yes, progesterone takes it away. When do I add estrogen? Or, for example, if they have, along with that or separately, heavy menstrual bleedings during the menopausal transition. So when do we add estrogen? In 2 situations. Either they develop more symptoms, which are not taken care of with progesterone, or they stop menstruating. So once they stop menstruating, there is no more estrogen enough to support the endometrium. So you see, the care of these women demands a specialist attention. It's not a GP. At this moment, it is not possible to be taken care by GP, even though the guidelines say so. I understand that it is it can take a lot, or that it costs, but we don't care. We deserve this. I mean, we don't even have enough information and understanding of this period of life. So if diabetes and hypertension have their own funds, then everything else should. So we need to invest more funds, give more funds to understand this period better, to organize care of these women better, and to be there every 3 months if necessary until we follow them through the perimenopause or menopausal transition, until we understand better what they are going through.
Thank you.
What
Thank you very
dose
much.
do you recommend? This is another question from our audience.
200 milligrams of micronized progesterone at the bedtime. Rarely they need 300 or 400 if the heavy menstrual bleed is non-contained by 200 milligrams. But from my experience, the heavy menstrual bleed, which is not contained with 200 milligrams, will be contained by IUD with LNG, and we use that as well.
And what type of progesterone do you usually recommend for menopausal transition?
Always micronized. Most of my patients take it very well. And for example, their brain is now different than they were 25. And if they were taking oral contraceptives at 25 and 35, now the same oral contraceptives are not working the same at the age of 40, 42. And they say simply that there is something that makes them nervous, more susceptible to mood changes and mood swings. So we start with micronized progesterone and we explain it is complicated, more time demanding for doctors because they will have a lot of irregular bleedings. I mean, menopausal transition, by definition, is the time of our life with irregular bleedings and breakthrough bleedings. So this is something that you want to say to them, look, you will have irregular bleedings, but understand that at least we are putting your symptoms under control, so we cannot take perimenopause away. It is much more easier to treat menopause or postmenopause. Postmenopause is so easy. I mean, you give the medication, you achieve the continuous levels of hormones, and a woman comes to you, she says, oh my God, you are the best doctor ever because everything is gone in 3 months. And I'm sure that all of you know exactly what I'm talking about. But treating menopausal transition, she comes in 3 months and she says, okay, this is better. I'm sleeping better, but I'm still not myself. So, we need to understand that. We need to say that, yes, you are going through a change. We cannot achieve the same as in menopause, but we can help you go through this stage as easier as possible.
Thank you, Dr. Marina, for the phenomenal discussion. Considering we have a very packed schedule, I will now close the discussion, but will ask you kindly if you could answer the dozens of questions that are in the Q&A box by message. And with this, I would like to give the floor to Professor Lambrinodakis so she can introduce our next speaker for today.
Thank you, Christina. It's my pleasure to introduce our second speaker, Professor Chana Jaisena. Correct, Chana?
Yes, it is. Perfect. Thank you.
Thank you. Chana is principal investigator and full professor at Imperial College in London, and he is also a consultant in reproductive endocrinology at the Imperial College, St. Mary, and Hammersmith Hospitals in London, and head of andrology for Northwest London Pathology Services. Chana will speak today about managing the climacteric symptoms in diabetic postmenopausal women. Chana, the floor is yours.
Thank you so much for that very kind introduction and the very generous invitation to speak. Can you see my slide okay?
Not yet.
Oh, okay. Let me just do this once more. Is this okay?
Yes,
perfect.
This is okay.
Perfect. Thank you so much, everyone, for this very kind invitation to speak among so many experts and to speak to so many people across Europe. So I'm going to present some really important data that I think challenges conceptions of mine and many clinicians, which I think is so important for women post-menopause who have diabetes. I have no complex. And I also want to acknowledge the excellent guideline who Irene has authored and led, and also the guideline for the European Society for Endocrinology, which we were both also part of, which underpins a lot of this work. So I'm going to first of all say that actually the relationship between menopause transition and diabetes is interesting because, of course, several factors cause insulin resistance in women during menopause transition. So there's obviously, we know that we all get heavier as we get older, but also independent of that, there's evidence that women independently of this, when menopause, will gain weight, but also visceral adiposity. And because of the shift in balance between estradiol and androgens, post-menopause, the ovaries still make androgens, and therefore this is more associated with an adverse metabolic status. And epidemiological studies suggest that there is an increased risk of menopause in in women with diabetes, so for example, there's a higher risk of diabetes of early menopause in women with diabetes, although the results are controversial. But women with surgical menopause have certainly a higher risk of diabetes. Now, does diabetes itself affect age of menopause? Now, this is where it is, I think, conflicting. So in type 1 diabetes, some studies have shown an association, but others have not. And in type 2 diabetes, I just wanted to cite this recent study that came out of the UK Biobank, where a very large sample of the population were tested and were followed up prospectively, and it's linked to their primary care records. And what it shows is that if we look at this table on the right, I'm just highlighting for you the results of model 2. And if you just correct for age, then what this shows is that diabetes risk compared to women with a normal menopause, where the hazard ratio is 1, having, say, premature menopause below 40, there appears to be a significantly higher risk of type 2 diabetes. However, if we look at this final model, model 3, where you actually correct, and the strength of this study is that you can correct for so many confounders, including BMI, waist circumference, blood pressure, but also when they were recruited before they went through menopause, lipids, but also glycemic indices, then actually you lose all that risk. And in fact, you have virtually the same risk of diabetes, regardless of the age of menopause transition. So diabetes itself doesn't appear to interact with the age of menopause. However, there's some fascinating and really important studies that came out probably about 20 years ago now that show what menopausal hormonal therapy does to glycemic indices. So the first was published in 2023, and it's a very famous study, the Heart and Estrogen Progesterone Replacement Study. And they took nearly 3,000 women post-menopause who actually had coronary heart disease. And at baseline, some of them had diabetes and impaired fasting glucose, but actually 2,000 of them didn't. And they randomized them to up to 4 years. Remember, this is an old study, and so there's a real predominance, and this was done in the US, of using conjugated equine estrogens and also medroxyprogesterone acetate. And what this analysis was to look at 2,000 women who did not have diabetes at baseline and followed them up for diabetes risk. Remember, half of them were randomized to placebo, half of them were randomized to menopausal hormonal therapy. And what they found was this: so that in the placebo group, basically about 10%, 9.5% of them developed new diabetes, but it was lower, 6% in the MHT group. So what this showed is that actually there was a highly significant reduction in new type 2 diabetes risk. And if we're wondering why this happened, well, fasting glucose actually on average increased in the placebo group, as one might expect with women getting 4 years older, but it didn't significantly in the MHT group. And then the WHI a year later did an analysis of their very well-known study. Remember, this was done in a relative, women, some of them, going up to the age of 79. 15,000 women were randomized to placebo and the same thing as in the HER study, so conjugated equine estrogens and MPA. And what they found was, again, a very clear separation in incidence of new diabetes. And they found that there was a reduction in insulin resistance after a year. So pulling this all together and then bringing in other strands of evidence from other studies, it's really interesting that there are several studies showing the same things, that when you're on MHT, you are reducing, you are almost turning back the clock in some of the inevitable things that do happen. So you're reducing visceral adiposity and central fat distribution, which is characteristic of the menopause transition. And also the KEEPS trial, it was very interesting. So it suggested some potential benefits in terms of weight and waist gain. and improvements in insulin sensitivity and glycemic control. So it's really interesting. There seems to be some quite unequivocal benefits. Does the route of MHT matter? Well, it's very interesting that the oral estrogen formulations appear to have stronger metabolic benefits, but of course, that we also know that in women in this age group, you will provoke more thromboembolic events, which could have cardiovascular implications. So transdermal is from our advice safer, but that might mitigate glycemic impacts. What about progestin? So as you'll note from the trials I mentioned, these were older synthetic ones. So progestins appear to reduce the metabolic benefits of estrogen, particularly if it's an artificial one with androgenic activity, such as meroxyprogesterone. So clearly, using micronized progesterone or its isomer dydrogesterone, whichever is available, would be advisable and better in terms of glycemic control and risk. So with all of this together, it looks to me like, and you may think the same thing, that MHT, should be ideal for women post-menopause with diabetes who are symptomatic. And the interesting thing is that actually, the adoption of menopausal hormonal treatment is much lower in women with diabetes compared to those who don't have diabetes. And I think the reasons are probably quite logical or understandable. So first of all, diabetes clinics are certainly in the UK very busy and very kind of metric driven, focused on cardiometabolic factors. And it may be that actually these conversations are not being had, women are not asked these questions. And also, I think there's a concern. There has been a concern amongst clinicians that actually giving these women who may have other risk factors of cardiovascular disease could be dangerous for them if they have MHT. And also, I think it's important to realise that women who have type 2 diabetes are more likely to have other things such as social deprivation or reduced education, so they may be less willing to come forward, which we know is clearly a negative factor in terms of getting treatment for menopause symptoms. They're often prioritized lower than those women who are much more willing to challenge their clinicians. So coming to the European Society for Endocrinology guideline, this is the key recommendation that I wanted to draw attention to. So we want to be very clear about this. Well-controlled diabetes is not a contraindication to MHT, and transdermal estrogen is preferred. So how should we do things? So clearly, I think there's a need for clinician and patient education, dissemination about the fact that actually diabetes is not a showstopper. It does not preclude, it does not contraindicate treatment. And MHT could actually improve glycemic indices. Clearly, it shouldn't be used as a treatment for diabetes. But it certainly could reduce risk of those who don't have diabetes. Transdermal estradiol is sensible for a group who may potentially have other cardiovascular risk factors. And I think it's really important to remember that this is part of a holistic plan in terms of diet and exercise. And I think one interesting thing is that because some of these patients may be on gut hormone therapies which reduce stomach emptying, it's possible that some of these, particularly the tirzepatides, could temporarily reduce absorption of these if taken orally. So I just want to finish up. I think the most important thing is actually remembering to ask about menopause symptoms in diabetes clinics. MHT reduces diabetes risk. There is strong evidence of that. And there's no direct evidence for harm, but transdermal is the preferred route in this group. And MHT should be part of a holistic plan, considering other lifestyle factors. Thank you.
So thank you very much, Anna. for your excellent presentation and for keeping the time as well. So the talk is open for discussion. And I would like to ask the first question from our audience, whether genetics are taken into account in the research. For example, if is involved in glucose production and estrogen, we know it is estrogen dependent. And according to the genotype, some women may have more change in their vessel compared to others. So how do you comment on this?
Oh, sorry, what was the last thing you said? Women may have more what? Sorry?
More atherosclerotic changes or vasoactive changes on their vessel, depending on their genotype.
Yeah, I mean, this is fascinating because I didn't present it, but we know that the presence of severe vasomotor symptoms highly interacts with the incidence and risk of diabetes. And I mean, looking at the literature, I'm not entirely clear on the reasons why. And it could be that it's a surrogate marker for, say, for vascular pathology. But obviously, Irene, it'd be interesting to hear your thoughts as well. And it seems that as with many things, this is an understudied area. So I don't see a clear association there. But what do you think?
Yes, I agree. But it seems that vasomotor symptoms are women-specific risk markers for chronic disease, not only for cardiovascular disease. I think Panagiotis will tell us about osteoporosis or sarcopenia.
We have another question from the audience. First, I would like to thank you, Professor Jayasena, for this exceptional talk. The Q&A box is full with questions. We have one coming from Agnes, and she is asking, should a pre-diabetic women be put on metformin or semaglutide to lose weight and improve sugar metabolism, or we should just start HRT?
What I don't want to do is give the impression that HRT should be a replacement for standard diabetes care. It's a hugely important. It's a numbers game, and we mustn't. And I sometimes we can get into the same argument with osteoporosis and things. Clearly, it's important and has benefits, but of course there are other therapies as well. And I think seeing it as a complementary treatment, but not a replacement, is important.
Yes, thank you for pointing that out. Time for another short question before closing the live discussion, and then we will ask you to please kindly type down the answers in the Q&A.
There are so many questions,
Professor Lambrinodaki?
May I pick one question from the many here in the chat? And this is a question for the whole panelists. So, what are the indications of testosterone replacement therapy in perimenopausal and postmenopausal women? Because we see in clinical practice that there is a huge increase in the prescription of testosterone. What should we do?
Yes.
Chana?
So this is something that I've looked very closely into the literature into this, and I agree that there is a very clear indication for persistent sexual symptoms of low libido, so what we call PMDD, critically in women who are optimally replaced on HRT, and that is a critical thing. And unfortunately, it's been used widely. Certainly in the UK, particularly in private clinics for other things such as cognition and well-being, but actually looking at the evidence, it is very unclear. And unfortunately, I have a theory that actually if you give testosterone as a kind of a first-line treatment before you have optimized someone, you could simply be increasing a pool of pre-hormone that's aromatized to estrogen. So it could simply just be, just an indirect way of supplementing their treatment. So if someone has persistent symptoms, I know it's not something to be done routinely, But in someone with persistent symptoms, I would make sure about absorption, I would make sure about compliance, and try to work with them to see whether we can optimize the treatment. But in a small minority of women, there may be a place for testosterone.
Mm-hmm. And do you suggest the doses of testosterone or the mode of delivery?
Yes. So about 5 milligrams daily is what I would call the sweet spot. The problem with that is that there is a very poor availability of female-specific preparations. And so the risk is that if you take a sachet of about 40 or 50 milligrams, whatever is available, then we ask people to give a very small amount, like a pea, like a tiny, tiny amount. And a pea means different things to different women. And so actually, some of these women, if you look at studies, accidentally are running levels of testosterone that are well into the male range. And we know that masculinization of the vocal cords and the voice box can occur very rapidly and is irreversible. So there's a big risk with this. And I think this risk multiplies the less careful we are about prescribing it in the first place.
Thank you. And one last question, because we have run out of time. So in women with established cardiovascular disease, established atherosclerosis, would you prescribe HRT?
As with anything, I think that you need to have a discussion. I would have a discussion with my patient and think, how important are your symptoms and how much does it impact your quality of life? And I like to have a very high threshold for taking treatments off the table. So in other words, yes. But if it was important enough to them, and I would talk to them about the evidence, and actually I don't see clear evidence of harm if given carefully, transdermally, of course, and ideally with a bioidentical, like a native progesterone. So absolutely. But if we give it non-selectively to people who may not have symptoms, then maybe that is a poorer case for giving it.
Thank you so much for your presentation. And I will give the floor to my co-chair, Christina.
Thank you, Professor Lambrinodaki, and thank you, Professor Jayasena, again for the exceptional talk. Now, it is my great pleasure to announce and introduce our next speaker for today, and this is Dr. Sara Vodopivec. Dr. Sara Vodopivec completed her residency in obstetrics and gynecology at the University Medical Center of Ljubljana. She is pursuing her PhD at the University of Ljubljana, focusing on pelvic floor trauma during childbirth. Today, her talk will focus on managing climacteric symptoms in women with a history of breast or ovarian cancer. Sara, the floor is yours.
Thank you, Christina, so much for introducing me. Let me just share my screen. So my talk today is going to be about managing climacteric symptoms in women with a history of cancer. I shortened it a bit because the central challenge in this group of patients is balancing the quality of life improvement with oncologic safety. It's important to distinguish clearly between different types of cancer and different types and different management paradigms in different situations. So the scope of the problem is that the burden of menopausal symptoms because of cancer treatment are increasing globally. More than 9 million women are diagnosed with cancer each year. And up to 40% of patients with gynecological cancers are premenopausal or perimenopausal at the time of diagnosis. What is more, about a third of breast cancer patients are premenopausal or perimenopausal, and also colorectal cancer rates are increasing in younger women. So the treatment and prevention of cancer cause the ovaries to shut down by surgery, by gonadotoxic chemotherapy, by pelvic irradiation, or anti-estrogen peroral therapy. And that causes induced menopause, which can be premature or early. And the problem with induced iatrogenic menopause is that it causes an abrupt hypoestrogenism. So cessation of menstruation following these therapies is called induced menopause, and it has more severe menopausal symptoms and higher negative impact on quality of life. As Professor Jayasena before said, even diabetic risks are higher in induced menopausal patients. And so what is more, improvements in oncologic therapies mean extended survival for many patients, and that also contributes to growing population that will have enduring consequences of treatment and of these symptoms through late phases of life. The problem with induced menopause symptoms is that it's not just the short-term impact on their quality of life, like well-known vasomotor symptoms, GSM with sexual dysfunction, urinary dysfunction, and decrease in everyday life quality. But what is more important, they have health risks that are enduring, and these changes can cause osteoporosis, increased cardiovascular risk and mortality, premature cognitive deterioration, and dementia, and all of that can increase in all-cause mortality. What I would like to point out today is that doctors still are in denial of how important the menopausal therapy is for women with cancer. There was a study published just last fall, or a survey actually, where in the United States only 63% of doctors selected yes for providing menopausal therapy for endometrial cancer survivals, and only 65% for ovarian cancer, epithelial ovarian cancer survivals, and not even everyone for the cervical cancer, which has no contraindications to use the hormone replacement therapy. So I would like to point out that it is important that we do not negate this field. So my humble experience is from a few months ago, where I had this 37-year-old patient who was a mom of two, and her chief complaints were, of course, menopausal symptoms like hot flashes, tiredness, burning in the vagina, insomnia, fatigue. When she was 2 years after extensive treatment for her adenocarcinoma of the rectosigmoid colon with posterior pelvic exenteration, and when she got a consultation with gynecologic oncologist at the oncology clinic, they suggested her just conservative measurements. And when I asked them why, they said, yeah, we always start only with conservative measurements, but she was 37 years old. So that's when I become even more interested into this topic. And the very important thing is, and the core principle is to individualize the risk. So we have to weigh the risk of cancer recurrence, and on the other hand, everything that patient has with the symptoms that they are experiencing. So the cognitive decline in mind, the low quality of life, the cardiovascular risk, and osteoporosis risk. And we have to know that not all cancers are hormonally dependent, that histologic subtype is critical in ovarian cancer, that receptor status is critical in breast cancer, that stage and grade are critical in every cancer because they may be very early diagnosed, and that the multidisciplinary discussion is recommended and important. Sorry. So let's take a look at oncologic safety for hormonal replacement therapy. Very important is that the therapy should be tailored to each individual. So what we have to consider is patient's age, her cancer type, has histologic properties, the time since diagnosis, the symptom severity, quality of life, her comorbidities, polypharmacy, her risk factors, pre-existing risk factors for chronic disease, and last but not least, her personal views and preferences. So if we go to the breast cancer, which is the most common cancer worldwide, it has 20% of the patients are premenopausal. And the pathophysiology about the breast cancer and menopause is that the treatment causes abrupt hypoestrogenism because of the treatment, which aims to block estrogen, who usually drives estrogen positive breast cancer. So the women receive gonadotoxic chemotherapy, ovarian suppression, and then even oral endocrine therapy. So their vasomotor symptoms are usually more severe compared to natural menopause. And What is more, the newer protocols prolongate the treatment, so the symptoms can be can last longer. And even in postmenopausal women who receive aromatase inhibitors, the treatment can cause aggravation of pre-existing menopausal symptoms. What shocked me a little bit when reading through literature was that menopausal symptom severity is actually a common reason for women to stop therapy for cancer. And that actually means increased morbidity and mortality from breast cancer itself. That's why experts are calling for change in this field. And a few months ago, this study was published. So about menopausal hormone therapy for breast cancer, what is the current evidence? This is a thorough literature review, the most comprehensive to date on the use of hormone replacement therapy for women who have been treated for breast cancer. And I would like to guide you through this paper a little bit. So an important thing when we have a breast cancer survival patient in front of us is to weigh of course, her symptoms, her view of the disease and of her situation, together with the risks that hormone therapy could bring to her. And these risks are dependent on the type of the cancer she had, because it's different if she had a carcinoma in situ or estrogen receptor positive cancer. Of course, the grade of the malignancy, then the route of the delivery, so it's whether we choose the systemic therapy or topical vaginal therapy, and also the type of hormonal therapy. In patients without uterus, we choose estrogen-only therapy, which is way less dangerous, so to say, than combined therapy, and body-identical hormones are better or less than dangerous than synthetic hormones, according to literature. So what does that review suggest or conclude in regards to breast cancer patients? First of all, let's take a look at genitourinary syndrome. So we usually use the vaginal low-dose topical estradiol, 10 milligrams twice a week, or even a new preparation with 5 milligrams twice a week. That means 0.02 milligrams weekly, which if you put this together, it comes to 1 milligram yearly. 1 milligram is usually the dose of one synthetic estrogen pill used for hormone replacement therapy. So it is a very low dose therapy. And what is more, the systemic absorption is minimal, and they proved that it becomes even less when the vaginal mucosa gets better, so when it heals a little bit. So this review concluded that vaginal estrogen as well as progesterone are unlikely to increase the risk of relapse of breast cancer death, mainly because there's minimal systemic absorption. And we can use topical estradiol for treating genitourinary syndromes in breast cancer patients. Moving on to vasomotor symptoms in this group of patients. Of course, in hormone receptor positive cancers, non-hormonal options are preferred. From those, the best results in the literature are for cognitive behavior therapy, but also some pharmacological options. Medications can relieve vasomotor symptoms up to 60%. And usually we use gabapentin, selective serotonin reuptake inhibitors, or SNRIs. The newer drug is fezolinetant. The studies for the use of fezolinetant in breast cancer patients had not yet been published, but I understand that they are under exertion. And in the United States, fezolinetant is not prohibited by the FDA in breast cancer patients, so can be used also in this population. However, many of these treatments also can have side effects like sexual dysfunction, increased risk of fracture, and also withdrawal and dependency. And we need to know that, according to studies, up to 1/2 of breast cancer survivors would choose to accept a small increased risk of recurrence in exchange for improvement in their quality of life. So we have to have in mind that some patients would prefer maintaining their quality of life as it is of great importance to them than the risk of recurrence of the disease itself. So what does the review say about that? In patients after ductal carcinoma in situ, they say that hormonal therapy can be cautiously used to treat menopausal symptoms, and that it probably does not increase the risk of relapse or death from breast cancer. And the same is for the estrogen receptor negative breast cancer, because the estrogen only therapy is unlikely to increase the risk, while combined therapy with the progestin may increase the risk of developing a new cancer, the second breast cancer. So when weighing all the pros and cons, the therapy can be cautiously used to treat menopausal symptoms in this specific group of women. In the contrary, of course, in patients after estrogen receptor positive breast cancer, menopausal hormonal therapy is likely to increase the risk of relapse, so we should not use it. Or they even conclude that can be used to treat menopausal symptoms, but with a high level of caution. And they also have an opinion on testosterone therapy after all 4 kinds of breast cancer. And they concluded that testosterone therapy can be offered a trial to treat low libido and sexual dysfunction, but as well as with caution, because the data is scarce. So that's what the evidence review concluded. They also provided a very illustrative a graph, so to say, where you can check what are the calculated risks with or without menopausal hormonal therapy. We don't have time to go through it, but I suggest you to have a look, because it's really informative when you should counsel your patients about it. However, this research group encourages all of us that we include any patient after breast cancer that would receive hormonal therapy into the proposed MENO ABC study that is published on this webpage, and you can check on it. I would now move on to the ovarian cancer. Most of the ovarian cancer, as we know, like 90%, is epithelial. And what they discovered when reviewing the literature is that hormonal replacement therapy actually significantly improved overall survival in ovarian cancer. So actually, we should be encouraged to think about including hormonal menopausal therapy in this group of patients. It is important, however, to distinguish between different subtypes of epithelial ovarian cancer. So in the high-grade serous ovarian carcinoma, which is not estrogen sensitive, we can prescribe hormonal therapy, as well as in mucinous ovarian cancer. On the contrary, low-grade serous ovarian carcinoma that has higher hormonal sensitivity and where they showed some therapeutic success with anti-estrogenic therapy is a contraindication for hormonal menopausal therapy. The same is for endometrioid ovarian tumors who are probably estrogen dependent, and for the borderline tumors that have potential risk of progression to low-grade serous carcinoma. For the clear cell carcinoma, the doubt is associated with the increased risk of venous thromboembolism in this type of cancer. That's why we should be cautious in prescribing hormonal therapy in these patients. The other are non-epithelial ovarian cancers, which can be germ cell tumors. These usually occur in younger patients where fertility-sparing therapy is usually the goal. But however, they could receive the hormonal therapy if needed, because these are non-estrogen dependent. Which is not the same with granulosa tumors, which are the most common sex cord stroma tumors that have hormonal activity and estrogen dependence. So the hormonal therapy in this kind of cancer is contraindicated. And now just a brief look on endometrial cancer, even though it was not the topic of this lecture, but it is the most common gynecological cancer, and around 15% of cases are among premenopausal women, and the numbers have been growing lately. For this type of cancer, in the early stage low-grade endometrial carcinoma, which is most of them, the hormonal replacement therapy does not worsen recurrence rate, disease-free survival, or overall survival. And this was a large data analysis that was done. On the contrary, in the high grade and non-endometrioid histology or advanced stages, FIGO 3 or 4, we should not offer hormonal replacement therapy because the data are just the opposite. And now just a brief overview of the patients with high genetic risk for gynecological and breast cancer, so the BRCA1, 2, and Lynch syndrome, who usually or often receive risk-reducing salpingo-oophorectomy in the younger age or hysterectomy. In these patients, the hormonal replacement therapy does not increase breast cancer risk. And we have to know that BRCA1 usually causes triple negative phenotype. So these patients with BRCA1 are even less prone to estrogen bad effects, so to say. While BRCA2 are more likely hormone receptor positives. And in patients who are after hysterectomy, they found out that estrogen-only therapy is associated with a 32% reduction in all-cause mortality. So combined therapy has more complex risk profile and needs to have, we need to have more caution when we prescribe combined therapy. However, the current guidelines say that these patients with high genetic risk who did not have breast cancer before should receive hormonal replacement therapy if needed until the natural age of menopause to offset the detrimental effects of estrogen deficiency after induced early or premature menopause. So to wrap up, what should be the management of menopause after cancer? In all women below 45 years of age who have prolonged amenorrhea after induced menopause after cancer treatment should be offered hormone replacement therapy, and that is at least until the age of their natural menopause, which is usually around 50 years of age. Of course, provided they do not have the contraindications. And the contraindications connected to the malignant diseases are estrogen receptor positive cancers or anti-estrogen cancer therapy. So how to start and how to follow up? The important is to estimate the cancer recurrence risk. This is usually done by oncologists who treat the patients. And then when we decide to start the therapy, the follow-up should be regular and consistent. And we should continually evaluate the risk-benefit ratio. We should offer regular breast examinations and mammography. And the duration of hormonal therapy is, of course, controversial, but at least until the woman's age of natural menopause. While for the vaginal local estrogen therapy, there's actually no time limit until when we can use it. So some take-to-work messages that I would like to share with you are, this should be an animation, but so sorry for the presentation, it's not working. So we should forget this, that cancer survival patient shouldn't receive hormonal therapy. I hope I busted this myth with the presentation, and that you will remember that cancer type and receptor status determine menopausal hormonal therapy safety, that hormone therapy is often underutilized despite the more severe symptoms these patients have because of the induced menopause, and that the reasons and concerns for that are unfounded. The menopausal hormonal therapy has favorable risk-benefit profile in most epithelial ovarian cancer, in the early stage endometrial cancer, in cervical cancer, and that it is not completely contraindicated in all breast cancer patients. However, the hormonal therapy is not recommended in advanced endometrial cancer, in uterine sarcoma, in endometrioid or low-grade ovarian cancer, but in the patients with high genetic risk, it is not contraindicated if they not have had the breast cancer before. And please remember that topical estradiol for vaginal symptoms, genitourinary symptoms in breast cancer and ovarian cancer survivals is safe, and we should offer it to our patients to improve their quality of life. Thank you.
Thank you, Sarah, for this truly exceptional talk. I have to say that for me, the technical difficulties regarding the presentation didn't have any effect. I loved your talk, and thank you for sharing your expertise, especially being an early career on this very important webinar and for representing NTOC, I will say wonderfully. We have a few minutes for very short questions in order to keep track with our packed schedule, and I will then ask you to please write down the answers in the Q&A box. The first question
we have
is, what is your
time for one
opinion?
question. Sorry, only one question.
Okay. What
because
is your
we're past
opinion
time.
on vaginal tamoxifen?
I'm sorry, on vaginal?
Tamoxifen.
Oh, I haven't read on that. Sorry, but I don't have opinion. In the papers, the recently published papers that I've gone through, it was not mentioned.
Okay. Thank you for that. And the next question, considering that this was
Short
not
one.
elaborated in detail, estrogen in women with active breast cancer or in women using aromatase inhibitors?
Probably missed the first part of it.
Do you use vaginal estrogen in women with active breast cancer or in women using aromatase inhibitors?
In my short clinical stage, I haven't tried using it. And I think that as I work as a primary care gynecologist, I wouldn't see those patients while they're in active treatment. But I believe that the paradigm should change, and they may receive at least the vaginal. They should receive the local therapy. They could receive it.
Okay. Thank you, Sarah, very much again for your talk. And
Thank
now
you for your
Dr. Sarah
patience.
will be answering your questions. And I give the virtual stage to my co-chair, Professor Lombrinodaki, so she.
Thank you so much, Christina. So I would like to introduce our last but not least speaker, Dr. Panagiotis Anagnostis. Panagiotis completed his basic medical training and earned his PhD from the Medical School of Aristotle University of Thessaloniki in Greece. And in 2024, he was elected Assistant Professor of Internal Medicine at the University of Thessaloniki. Panagiotis will talk about managing osteoporosis risk during the climacteric and early menopausal stage. Panagiotis, the floor is yours.
Hello to everybody. Dear Professor Lombrinodaki, thank you very much for your kind introduction. It's indeed a great pleasure and a great honor to join this wonderful panel. I am very grateful both to EMAS and the European Society of Endocrinology for this honorable invitation. So let me share my screen. I hope this is visible. Is it?
Yes.
Okay, thank you. Thank you very much. So, after displaying my conflict of interest, nothing of this has to do with the purpose of this presentation. We're actually going to discuss about changes in bone metabolism during the menopausal transition, ways to assess fracture risk, and finally, how should we manage or how can we manage women during the climacteric and their early postmenopausal stage. With regard to the first topic, as these were wonderfully mentioned by Professor Marina, I'd just like to remind that if we set this line at the final menstrual period, when we're discussing about perimenopause, we actually are referring to the period that precedes this time point during a woman's lifespan, that is 1 to 3 years, and it is considered as late perimenopause. The years preceding this stage are considered as early perimenopause, and after the final menstrual period, the first 2 years are considered as the early stage of postmenopause. Data from the well-known study, the SWAN study, shown the grade loss of efficacy here comes to about 1.6 to 2.3% per year with regard to the late perimenopausal stage, and it is further increased to 2 to 3.3% annually regarding the postmenopause, the early postmenopausal stage. whereas it is to a lesser extent observed for the total hip. And if we can also see about the effect of some risk factors such as ethnicity, there is no effect on this regard, whereas this bone loss is affected by BMI, actually by body weight. And as you can see here at the bottom picture, at the bottom right of the slide, you can see here that this rate of loss is greater for women with lower body weight, lower than 61, and for the 61 to 77 kilograms, and it is not so obvious for women who weigh more than 77 kilograms. With regard to the rate of bone loss, actually, it is not the final menstrual period, the critical point that determines the bone loss, since it starts during the ages that precede the final menstrual period, but it peaks at this stage that it's about 1 to 2 years after the final menstrual period. And as you can see here, it is actually from 0.5 to 3% annually. You can also see here that the microarchitectural deterioration, excuse me, involves both trabecular thinning, cortical porosity, and there are also some geometrical changes. That means periosteal apposition, which partially compensates for endosteal resorption, but net cross-sectional moment of inertia declines, which reduces resistance to bending forces. We are all familiar with this slide that estrogen clearly affects bone metabolism, both directly and indirectly. It actually induces the differentiation of osteoblasts, and it suppresses osteoclast action and differentiation. It also acts at the osteocyte level and indirectly through its estrogen receptor beta. There are also some other hormonal contributors, which are FSH. It has been shown that FSH can stimulate osteoclastogenesis. So if we have higher FSH levels, that means increased osteoclastogenesis. Also, progesterone shows a decline. So that means that has a mild effect on the osteoblast stimulation. Cortisol also contributes, which means that it can suppress osteoblast function since it may be increased during menopause. This is also the case for androgens. And another aspect is the increase in parathyroid hormone levels, since estrogen seem to normally suppress PTH levels. So in this case, the decline in estrogen is related to increase in PTH levels. What have you learned from this well-known study which involves menopausal transition, the well-known study of women's health across the nation, the SWAN study? Except for the well-documented decline in bone mineral density, we can also see the decline in trabecular bone score, which is an independent marker of bone strength and declines by 1.1% annually from 1.5 years before the final menstrual period, with losses of 6.3% over the menopausal transition. This microarchitectural damage in the trabecular structure cannot be corrected by anti-disruptive therapy and should also be taken into account. Some other aspects are that BMD at the time of menopause is a highly significant predictor of future osteoporosis, so we must take this under consideration. And again, premenopausal BMD values at lumbar spine and rate of decline till early menopause are also an independent risk factor for future fractures. We're also familiar that during these stages, there is an increase in vasomotor symptomatology from either mild or moderate to severe in the majority of women. But is there any association between the severity of symptoms and bone health? This issue has been addressed by our team with this meta-analysis published 2 years ago, showing that the severity of symptoms really matters with regard to bone health, although there was no association with fractures, but there was indeed an association with increased risk of osteopenia and osteoporosis. That means if women experience moderate to severe symptomatology, are at about 1.5 higher risk for developing osteopenia and osteoporosis. This was also seen for mild vasomotor symptomatology versus no vasomotor symptomatology, but it was to a greater extent for moderate to severe symptoms. This had to do also both for lumbar spine and to a lesser extent for femoral neck BMD, and should be taken under consideration. But how can we assess fracture risk during this climacteric and early menopausal stage? We know that osteoporosis is defined if we have a bone mineral density with values lower or equal to minus 2.5. This is the definition provided by the World Health Organization. But if we see the indications for BMD screening by the International Society of Clinical Densitometry, it is generally recommended for women 65 years or older. And there is a point here that during the menopausal transition, with clinical risk factors for fracture, such as low body weight, prior fracture, or high risk medication use, this population may be considered for earlier screening. But take also into account that the well-known FRAX tool has not been validated for pre and perimenopausal women. So the question that emerges is, should perimenopausal be considered as pre or postmenopausal women with osteoporosis? If we consider them, which is more correct, as premenopausal women, since they need to have at least 12 months of amenorrhea, we should use these criteria provided by the International Society of Clinical Densitometry, which propose the Z scores rather than T scores, and Z score lower than minus 2 should be considered as below than the expected range for age. Therefore, these criteria use menopause as a criterion rather than age for low BMD. And the consensus that has been developed by the IOF and the ECTS societies clearly indicates that we need also vertebral fracture, either alone or with multiple fragility fractures, combined with low BMD, either with Z or with T scores, in order to use the term osteoporosis for this population. So if we do not have fractures and low BMD lower than minus 2, we cannot use the term osteoporosis. We should never forget that we should always check and exclude secondary causes of osteoporosis, such as inflammatory disease, endocrine diseases, hyperthyroidism, type 1 diabetes, growth hormone deficiency, hyperparathyroidism, malabsorptive diseases, and psychiatric diseases, and medications and other diseases such as cancer. We also should take into consideration the effect of the age of menopause, because women that are diagnosed as premature or early menopause are at increased risk for fracture. So it is an independent risk factor for fractures, as we have shown about several years ago. And finally, how can we manage these women with low BMD during the perimenopausal and early postmenopausal period? If we look into the international and actually the European guidelines, we should assess them by the FRAX tool. Of course, these women should be indeed postmenopausal in order to use the FRAX score. And this score should be actually validated according to the country. But in any case, we should use the intervention threshold. That means if the score that has been calculated for our patient should be either in the high risk or in the very high risk category in order to prescribe an anti-osteoporotic medication. But what about low risk patients? Because the vast majority of these perimenopausal and early postmenopausal population are at low risk. These guidelines clearly state that we can consider menopausal hormone therapy or SERMs, selective estrogen receptor modulators, in order to reduce the risk or to prevent the development of high risk in the future. Optimal calcium supplementation and vitamin D supplementation should be also considered, because both of these supplementation, not either monotherapy alone, both of these supplementation may reduce fracture risk, especially in the older population. We all know that menopausal hormone therapy is indeed effective both for women younger than 60 and older than 60 years for reducing all three types of fractures: vertebral, non-vertebral, and hip fractures by about 70%, 35 to 70%. But what about this specific population, perimenopausal and early postmenopausal? There are actually some studies. The most representative study is the PERF study, whose purpose was to determine whether the administration of HRT for 2 to 3 years in the early postmenopausal population really provides long-term benefits, such as the prevention of bone loss and osteoporotic fractures. As you can see here, during this actually were data from 4 RCTs from Denmark, and you can see here that during the HRT, during the study duration, HRT really prevented the expected bone loss compared with placebo, and after HRT discontinuation, there was indeed a bone loss, but this rate was lower than that observed with placebo. Although this was not shown in all these 4 studies. So these data clearly document a beneficial effect of HRT in this specific population. You can see the dose that were used, mostly 2 milligrams of estradiol with various types of progestogen. And what also was shown, it was that this use for 2 to 3 years was associated with a reduction in the risk of vertebral fractures of 53%, which is of utmost importance, although there was no effect on the risk of non-vertebral fractures. The other large category is bisphosphonates, and this category has clearly shown data about the preservation of bone mineral density and the suppression of bone turnover markers in early menopausal women. This is our specific population that we're discussing, and this meta-analysis clearly answers to this question and shows that there is an increase in BMD of about 6% for lumbar spine, 3.9% for femoral neck, and 4% for total hip for all bisphosphonates. There were data for alendronate, risendronate, impadronate, and zoledronic acid, one study actually. There is another study which compared different doses of alendronate with HRT, and this showed that HRT produced higher increases in bone mineral density in women under 60 years of age. Of course, we should not forget the effect of serums, that is raloxifene. You can see here in this study, in this 3-year double-blind randomized placebo-controlled trial, showing that raloxifene at the dose of 60 or 150 milligrams showed an increase in bone mineral density both in lumbar spine and femoral neck. And the other player is the TSEC, the combination of basedoxifene with conjugated estrogen, and the data from this study that was published about 18 years ago showed that basedoxifene in women in which menopause was documented more than 5 years showed a clear increase in bone mineral density, which was higher than raloxifene. This gray spot is for raloxifene, whereas for women in the early postmenopausal period, the TSEC provided beneficial effects both for total hip and lumbar spine, whereas this was not evident for raloxifene. So, to answer for this question, if perimenopausal women should be considered as premenopausal or postmenopausal, we should also take into account that there are no fracture data for this population, and of course for the premenopausal population, there are some guidelines that can be followed. This is from by the study by Pepe et al., published 6 years ago, showing that we should investigate for causes of secondary osteoporosis. If they are present, we should treat the secondary cause. If they are absent, this should be regarded as idiopathic osteoporosis. And there are data for bisphosphonates, denosumab, and teriparatide. They do not mention something about menopausal hormone therapy. And the other group by the IOF and ECTS has proposed a classification according to fracture risk, and if we have a fragility fracture or multiple fragility fractures, these women should be considered as very high risk, and we should use anabolic therapy, that is teriparatide, abaloparatide, or romosozumab. If we have z-scores below -2 and 1 fragility fracture, we can use either anabolic or antidisruptive therapy. And for women with at lower risk, they actually suggest to be managed as the initial management. As for every person with that, we suggest optimization of calcium and vitamin D, regular exercise, avoidance of smoking and alcohol. And they also suggest to repeat DEXA scan after 1 to 2 years, depending, of course, of the T-score. To summarize, the bone loss, which accelerates substantially in late perimenopause, this continues at a similar pace in the first postmenopausal years. Body weight seems to be a major determinant of the rate of menopausal BMD loss. However, except for lower BMD, we should also take into consideration that the loss of variant estrogen leads also to loss of trabecular integrity, with a significant contribution to fracture risk in later life. DEXA scan remains the gold standard for the determination of the menopause-associated bone loss. However, we should always assess risk factors for fracture and to exclude secondary causes of osteoporosis. The present methods, such as the FRAX tool, cannot be used for the perimenopausal population. It can be used, of course, for the early postmenopausal population. And for the former population, these intervention thresholds are not suited for early intervention. But if we have a patient with low BMD in the early menopause, this can be treated either with MHT or with SERMs or with bisphosphonates. We have data on this regard from randomized controlled trials in order to prevent further bone loss, to prevent microarchitectural damage, and of course the onset of osteoporosis and potentially fractures in later life. We do not have data for fracture risk reduction, but we have indeed data for a beneficial effect on preserving and further increasing bone mineral density for 2 or 3 years, as I mentioned before. This approach of bone mineral density and fracture risk assessment at the perimenopausal and early postmenopausal period should be validated, of course, in future well-designed studies with fracture outcomes as their endpoints. Thank you very much for your attention.
Thank you very much, Panagiotis. This was wonderful. So I'm sorry that we do not have time for questions. And if you please, can you answer the questions in the chat?
Of course.
And the open questions addressed to you in the Q&A chat.
Sure.
Thank you so much. And I will pass the floor to Christina. Thank you, Panagiotis, to introduce our case presenters.
Thank you, Professor Lambrinodaki, and congratulations, Professor Anagnostis, for the outstanding talk. We are now moving to the multidisciplinary case discussions we have mentioned at the very start. And I think that this part of the webinar gives us the opportunity to actually bring together different specialties and perspectives and to see how we navigate real-life clinical complexity. Before I introduce our case presenters for today, I would also like to introduce the representatives from ENTOC and VATOC. I will introduce Dr. Mert Ishak Kaya, who is a resident physician specializing in obstetrics and gynecology at Ankara Bilkent City Hospital. His academic interests include women's health, surgical innovation, and cancer biology, and he is an executive committee member of ENTOC, which stands for European Network of Trainees in Obstetrics and Gynecology since June 2025. It's a pleasure to have you with us today at this joint event, and I will ask Professor Lambrinodaki to introduce Dr. Rafal from VATOC.
I would like to welcome Dr. Rafal Zadikovic, who is a Polish obstetrician gynecologist and women's health advocate working at the intersection of clinical care, global health, and gender equity. He's involved in international collaborations with organizations including FIGO, WHO, and Doctors Without Borders, and combines clinical expertise with policy education and humanitarian engagement.
Thank you for a very nice introduction. I'm happy to be here with Mert. We both represent Europe and TOC.
Thank you. Thank you. Thank you very much for accepting to come here today. With this, I would also like to invite all speakers who delivered outstanding talks today to join us for the MDT discussion, and also to again remind the audience that we'll be sharing short polls during the case discussions in order to see how the audience thinks about managing these clinical challenges that we'll be discussing. Our first case presenter for today is Dr. Aspasia Manta, who is an MD and research fellow in endocrinology and diabetes at the University of Birmingham in the UK, with clinical and research interests in women's health and metabolic endocrinology. Dr. Aspasia, I will ask you to share your presentation and take the virtual stage.
Let me know if you can see my screen, everyone.
Yes, okay.
Good afternoon, everyone. Thank you for the introduction, Christina, and thank you for the opportunity to present this case. So I will present a case of a woman with progressive hyperandrogenism many years after menopause, which raised some diagnostic and management challenges. This is a 66-year-old woman with significant metabolic comorbidity. As you can see, she has long-standing type 2 diabetes, obesity with a BMI over 40, hypertension, and dyslipidemia, as well as diabetic complications. She also has a previous history of PCOS, and she went through menopause around 10 years ago. She was referred mainly because of progressive hair loss and biochemical hyperandrogenemia. At first glance, some degree of hyperandrogenemia might be expected in a woman with a background of PCOS and significant metabolic comorbidities and possibly insulin resistance. However, what was clinically concerning was that the androgenic features appeared to be progressing in the postmenopausal period rather than stabilizing or even improving. So this change in pattern was the main trigger for further investigation. If we look at the timeline a bit more closely, we can see that she initially reported hair loss and weight gain several years ago, but more recently, she developed alopecia, clinically significant hirsutism, and clitoromegaly, together with an episode of postmenopausal bleeding. If we look at her lab results, we can see that her testosterone level showed a progressive rise over time, eventually reaching quite high levels that raised concerns, but showing a kind of downward trend in the most recent results. She underwent an extensive endocrine assessment with the measurement of all these hormones, as well as imaging with pelvic MRI and a CT, chest, abdomen, and pelvis. And at this stage, we had several possible causes of androgen excess that we were considering.
And now I will ask Lena to share the poll and the audience to select the answer that you think fits best. We'll leave the poll open for the next 10-15 seconds. Okay, this is interesting. 10 more seconds.
Yes, to those who are not viewing the poll, perhaps if you can click on the three dots that you will have in your Zoom dashboard and click on polls, you might be able to see it.
Many thanks, Lena, for the assistance. Okay, we can now end the poll and share the results. Okay, can you see the results?
Yeah, it's being shared at the moment.
Yes.
Okay. Now I would ask Dr. Manta to continue her presentation and we can shortly kick off the discussion. Thank you, Dr. Manta.
Thank you. Thank you all for voting. So in this case, we considered four main possibilities. Postmenopausal PCOS, ovarian hypertrichosis, viralizing ovarian tumor, and adrenal androgen excess. Taking into account the clinical picture and most importantly, the investigation findings and the imaging findings, our leading considerations were postmenopausal PCOS and ovarian hypertrichosis, although the other causes can be completely excluded. In terms of management, the initial focus was on optimizing her metabolic profile with tirzepatide. However, the key question remains on how to best address the androgen excess itself. So options that currently are under consideration include a trial of spironolactone, a trial of a GnRH analog in order to help clarify the ovarian androgen excess, or a potentially definitive surgical management with oophorectomy. The final treatment decision is still pending, shared discussion with the patient. But in the meantime, the plan is for short-term monitoring of testosterone levels and longer-term follow-up focusing on the cardiometabolic risk. So this case raises the practical question of how we should approach significant hyperandrogenism presenting after menopause, particularly when imaging does not identify a clear cause. I kept it short, that was it. Thank you all for listening.
Thank you. Thank you, Dr. Manta. Now I will ask all the speakers and all the moderators to jump in, I would say, and discuss how would they tackle these challenges, what would their treatment option be. We would love to hear from all the endocrinologists, the gynecologists here. Professor Jayasena, I saw a hand.
Yeah, so it's a lovely case. I've managed a couple like this. I don't remember seeing the adrenal androgens, but from the level of how high the testosterone is, it points that the predominance of testosterone points to an ovarian source. But I would want to confirm that the DHEA and androstenedione are not markedly raised. In terms of, I don't know if you have that or I missed that off the presentation.
We do. They were normal.
They were normal. So I don't think the spironolactone will be terribly effective. And what we need to do is find the source. And we have used either GnRH agonists or antagonists to basically remove the stimulation by the pituitary. And if it's psychosis, then it should completely abolish the testosterone. Whereas if it's a tumor, then it will be autonomous. So that would be my view.
Professor Marina?
Yes, I agree. Although we did have a couple of patients who had intraovarial tumors, so they were not seen on imaging, but we did go, and the testosterone levels were much higher than this. So clinically wise, it may be a PCOS, persistent PCOS, and then I would consider cyproterone acetate alone to see if we can tackle the complaints, the symptoms that she has. I don't know if it is available in all countries. Spironolactone, absolutely no effects. I agree completely. Or yes, after all, take out the actions of pituitary, and then you have the results at the primary organ as well.
Thank you very much.
We have to say that some ovarian tumors do not visualize in imaging procedures, so we have to be cautious about that. And the Generate approach, I think, will clarify the cause, as Chana said. So, Sarah, would you like to comment?
Sarah, Mert, Rafal.
Gynecologist?
Sorry, I have not much. I don't have much experience with this kind of patient so far. So I'm happy that we have this joint webinar with endocrinologists. That we often miss the opportunity to learn from you as gynecologists. So yeah, we in Slovenia particularly we try to also establish this connection more. So thank you for all the knowledge that you share with us.
Panayotis?
Yes, actually, I would be very, very cautious for these patients. I would closely monitor them since perhaps we may miss an ovarian tumor. I would be more in favor of generate agonists. There are some case reports showing that there is a benefit with regard to hair loss and hirsutism and perhaps other signs. But this effect is not maintained after stopping, after discontinuation of generate agonist therapy. Although, to the best of my knowledge, there is one case report mentioning that it may be maintained for perhaps 6 or 12 months. I would insist on her cardiometabolic health to reduce her body weight. And of course, I would suggest other cosmetic measures for further discussion. But I would not be in favor of oophorectomy for these patients. Of course, if we have a clear image that there is no sign of ovarian or adrenal tumor.
Thank you, Panayotis. Rafal or Mert, would you like to comment?
Actually, we had a patient like this who had a previous hysterectomy in Turkey, Ankara, and she was about 65 years old and she had virulent symptoms. And we performed oophorectomy and she had an ovarian tumor. And in ultrasound and imaging, it was totally normal. So we prefer actually in Turkey the oophorectomy. That's all I can say.
Thank you.
And do you
Rafal?
remember how high was testosterone?
Actually, it was around 300 or something like that.
Thank you, Rafal. Do you have any comments?
No, nothing to add from my side, but I'm also quite familiar with referring to oophorectomy in Poland.
Okay, I would like to thank Dr. Spasiamanta for delivering a fantastic case presentation, and of course to all the speakers for sharing and moderators for sharing their expertise. And now I would like to invite and introduce our next case presenter, and this is Dr. Elisa Lambeck. She is a consultant endocrinologist with a master's and PhD degree in neuroendocrinology. She is also a medical coordinator of the Molecular Genetics Lab at the State Brain Institute in Rio de Janeiro, Brazil, focusing on pituitary tumorigenesis. Today, she will be presenting us a case on when estrogen meets cortisol, a cardiovascular collision. Elisa, the floor is yours.
I thank you for the introduction and for this opportunity. Let me share my slides. Can you see it? Yeah. Okay. So I'm going to present a case that's about Cushing's syndrome and if we can or not replace estrogen in this patient. So this is a 47-year-old patient. She works at a pharmacy. She's married. She has obesity. She doesn't work out. She has a family history of type 2 diabetes, but she's only pre-diabetic. She has hypertension that is controlled now with 3 antihypertensive. And she has Cushing's syndrome. It's ectopic ACTH secretion from a bronchial carcinoid that unfortunately metastasized to the liver to the chest and to the brain. She took out the primary tumor. She did a lobectomy, and she took out the biggest liver metastasis, and she did radiosurgery in the lymph nodes and the central nervous system. And she's also using temozolomide as a chemotherapy, lanreotide and ketoconazole for the Cushing syndrome, and her hypercortisolism is controlled, but only during the last 4 months. Her OBGYN history is that she had 2 C-sections. She has 2 boys, aged 8 and 10. And for the last 12 months, she's in amenorrhea. She has hot flashes. She can't sleep at night because of the night sweats that are very intense. She has a mood irritability that could be because of a menopause or the Cushing syndrome. She has no libido. She has vaginal dryness, urinary urgency, and she can't lose weight. And although she has more than 45 years old, I ordered an FSH because I didn't know if the amenorrhea was because of the Cushing syndrome or because of the menopause, and it's menopause, so it's high and estrogen is low. So as I said, she has a prediabetes. She also has osteoporosis with a low T-score below -2.5 and also a low Z-score, probably because of the Cushing syndrome, but she has no vertebral fractures, and her breast and uterus are normal. She has now 2 normal UFCs, a normal ODST, so her Cushing syndrome is controlled. Basal, cortisol, and ACTH are also normal, and thyroid, kidney, and liver functions are normal. So she was diagnosed with menopause and osteoporosis. And Dr. Sarabinovska, do you want to?
Yes, thank you very much, Elisa. Now I would ask Lena to share the poll once again for this case so the audience can vote. Thank you. We will leave the poll open for the next 15 seconds. Okay, I'm sharing the results. Can everyone see? Okay, great. We will discuss this after Dr. Elisa finishes her case presentation.
Okay, so this, I'm part of the 15% that voted for low dose vaginal estrogen therapy, because I don't know if I can do any systemic therapy for her, because we know that Cushing syndrome is a prothrombotic state, and even in remission with controlled hypercortisolism, we know that the thrombosis risk is high for the first 6 months after remission. So I don't know if I can do a systemic therapy, and if I can, should I do a transdermal estradiol and micronized progesterone? So I would really like to hear your opinions, please. Thank
Thank
you.
you, Elisa, for the outstanding case presentation and the very interesting case. I would now invite the speakers and the moderators to give their opinion, insights, and inputs on this. Professor Jayasena, Marina.
Yes.
Anastasia. Yeah.
Wonderful
Professor Marina?
presentation.
Yep.
Yeah. Wonderful presentation and a very important dilemma. I just want to add that you had every right to measure gonadotropins. The guideline is where it says do not measure after over the age of 45. It is for general public, not for Cushing's patients. So absolutely we want to know as much as we can about this rare disease, and ectopic is even rarer than the others. So as I understand, your patient is now young, so she's early menopausal. well, not early, she's 47, but still early in postmenopause. And she has all these risks from hypercortisolism that she has suffered before. So her bone is already damaged due to hypercortisolism. And you had every right to think of whether it is okay to give her MHT or not. So what I would do is wait just a little bit, wait for the 6 months window to pass, to evaluate, to see her if she's doing well. She is, I'm guessing, taking some sort of, she was not, yeah, she was not, did she have like a chronic treatment that she had after the surgery?
No, after,
Because
I'm sorry, she's using a ketoconazole for the hypercortisolism and for the
after
metastasis.
surgery.
Yes, after surgery. And for
Oh,
the
it is a persistent hypercortisolism.
and for the metastasis, she's on lanreotide and
Oh,
temozolomide.
I didn't get that. Okay, sorry. Yeah.
Yeah.
This is complicated. But do you have like pathohistology, or can you perform the so yeah, so if I can if we are going to discuss, so there are two questions. One is whether the tumor itself has some sort of receptor positivity, which worries us. The second is exactly what you were thinking of, which can be ameliorated with transdermal treatment, and then we should not be worrying about it anymore. So yeah, maybe the only one would be if the tumor is positive for any sort of receptors that would be in collision with our treatment.
Okay, we have the tumor, we can test it. Thank you.
Shana?
Thank you. I was trying to hide. So I think this is a really brilliant and challenging case. And I would, I mean, it sounds like this patient has been through a lot and has very severe symptoms. But I think regardless of, I mean, there are several cross-sectional studies suggesting an absence of thrombotic risk with transdermal disease, but this is a very high-risk patient. So, we're in an evidence-free zone. And the truth is, I don't know what I would do. And I think it would very much depend on the severity of symptoms and quality of life. I would probably be minded to consider treatment if it was severe and would make a big difference. But I would want to do this as a joint decision with oncology and the patient. But the truth is, I don't know.
Thank you. Thank you. Sarah, what's your opinion?
Yeah, well, again, that's way beyond the scope of my knowledge. It's a really complicated endocrinology case. If I got this patient, I would consult with endocrinologists and more experienced gyne and endocrinologists for their expertise. But as I understood, the dilemma was if she was if the estrogen would cause greater cardiovascular risk because of the hypercortisolism. And the answer is no, as I understand you, right, Professor Marina?
Sorry?
My thinking when listening to all this was what Elisa presented is the dilemma. Her dilemma was if estrogen therapy would increase the patient's risk for cardiovascular events or deep venous thrombosis.
Yeah.
And
So
would
I
say
don't,
no.
if it is a well-controlled disease, then I don't think that there is any higher risk than usual. But if it is not, then all cards are on the table. But if I have understood well from the last slide, maybe you can share it again. We have seen that her cortisol, I thought that she suppressed. But then maybe I've misunderstood the slide. So maybe you can share the last slide again, so we can go through it in a multidisciplinary way, as in, yeah.
Oh, yeah, Professor, now she's suppressed. She has no hypercortisolism, but we know that, at least in Cushing's disease, that the thrombotic risk is increased even after the patient is cured with surgery during the first 6 months of surgery. So like she's still in her high prothrombotic risk. So
yes, but she's cured now. So she's not taking ketoconazole anymore. At this moment, post-surgery, basal cortisol is 267, which is just, I don't know if she has any signs of dysfunction of HHA axis. So urinary free cortisol is normal. She's suppressed, so I would consider her at this moment eucortisolemic. And the only risk that I would take into consideration is exactly the one that you've mentioned during your talk. It is the post-surgical risk, which lasts in Cushing's patients. And I would wait for this window to be closed. And, as Professor Chana said, in MDT, talk about further steps, but would perform the analysis of the tumor as well.
Professor Jayasena?
Thank you. Panagiotis, do you have an opinion on this?
Sure. This is a very interesting and complicated and, let's say, multifaceted case. There is no clear answer that fits for everything. Actually, I would prioritize our main concerns. These patients suffering from Cushing's syndrome are by definition at high risk for cardiovascular disease. Their mortality ratios are more than twofold compared with the general population. So I would be more aggressive with regard to her cardiometabolic health, her lipids. I didn't see the lipid panel, and I would insist to low LDL levels. I would prioritize her diabetes risk. And with regard to her bone health and vasomotor symptoms, we have two choices. The first choice is to prescribe menopausal hormone therapy systematically, that is transdermal, of course. We should avoid the oral route. However, I am pretty much concerned that this would not have so much effect on the T-score. There is a very nice paper by the American Society of Bone Mineral Research showing how can we expect, how high can BMD go with with the antipsychotic agents. With T-scores of minus 2.8, we could not expect very much increases in BMD only with estrogen. So my second choice, actually my first choice, would be to give denosumab and perhaps fezolinetant for the vasomotor symptoms, or elizanetant that is already approved, and of course vaginal estrogen. If her symptoms insist, I would consider also menopausal hormone therapy in order to cover the vasomotor symptomatology. But again, her cardiometabolic risk is the first priority, and of course we can have the best available option for her bone health and of course the vasomotor symptoms as I mentioned.
Thank you, Panagiotis. Bert, would you like to comment?
No, thank you. I agree with Sarah. It's further our perspective view.
Okay.
Thank you. Thank you for all the comments.
Rafal?
Yeah, sorry, nothing more to add by my side, but what's interesting from my perspective is that you not always give hormones, yes, but for example, as Professor mentioned already, some more, let's say, direct drugs, especially to some specific symptoms to treat them. Yeah, thank you.
Yeah. Thank you so much. So I think we've come to the end. So I would like to thank all the speakers for their wonderful presentation. And for the live discussion, it was very educative indeed. And I would like to invite you all attendees to join the second session, which will focus on urogynecology. So attendees will use the same link as today. The webinar is recorded and will be available shortly on our website. So if you miss it, you may watch it asynchronously. Thank you all and have a nice evening. Thank you so much.
Thank you very much.
Thank you.
Before we wrap up, I would like first to thank the case presenters and all the speakers for delivering exceptional talks. And I would like to thank first on behalf of the European Society of Endocrinology as representing its early career committee, but also on behalf of EMA's early career working group. I would also like to invite you to join us tomorrow, where we will be sharing and also announcing, let's say, the best presentations for today and tomorrow case presenters. Thank you very much and see you all tomorrow.